All right, everyone. So we're live with our SimPulse Live today. We have the usual suspects in attendance here. Myself and John and Bill will be here to educate and entertain you for about the next 50 minutes.
And I just had the opportunity, just waiting for people to trickle in here. I just had the opportunity to join a simulation with the folks at the UW School of Medicine, Dr. McAdams and Dr. Trin, and a couple other people were joining, and they were just running a simulation, and we ran some video, captured some video while that was happening, so I can share that as we get going today, since it is Pediatric Simulation Month, VR Pediatric Simulation Month here at Acadicus. So
Yeah, that sounds great. I'd love to see that. I mean, that's really awesome. I'm pulling all the Q&A and all of that stuff, keeping it out here so that I can keep an eye on it if need be.
sounds good. And as we get started, I just wanted to make a note that April 19th, mark your calendars, April 19th at noon Central, we are going to have a pediatric VR simulation panel with Doctors McAdams, Dr. Trin, Dr. Sarah Trin, Dr. Nick Slayman is going to be joining from Nemours DuPont Children's Hospital, and Dr. Jeffrey Jacobson from Boston Children's Hospital. We're going to have a panel discussion April 19th, noon Central. So definitely mark your calendars. That's going to be a fantastic event. So we'll play this video in a little while, and you'll get a sense of what the folks at UW are doing, and hopefully we can get Dr. Sleeman and Dr. Jacobson to share more about what they're working on with Acadicus too. So
Yeah, that's definitely something you don't want to miss. Dr. Sleeman has been working with Acadicus for a really long time, and he is an expert. So that is definitely not something that you would want to miss.
Yep.
yeah, this morning, Dr. Slayman has been working on some 3D recordings for a CVL procedure that we're developing for NSU. So NSU has been a client for a long time. Dr. Elizabeth Oviawe is the guru there at NSU that's been leading the charge and bringing them into the new dimension here. And so they've built a bunch of different scenarios, and the last one that we're completing is the central venous catheter insertion step-by-step procedure. It's a standalone kind of self-guided experience, and we have a 3D recording of a subject matter expert. In this case, Dr. Slayman is going to be teaching the steps of central venous catheter insertion. So that'll be in the shared library. You'll be able to check that out when it's done, probably later this month, if not early in May. So we're looking forward to that. So Dr. Slayman's been doing a lot of cool stuff. I think he was one of the first active customers. I met him at IMSH, the exhibit that we launched Acadicus at in 2019, January. And he came up to the booth and told him what we were working on. And a few weeks later, he sent me a text message and say, hey, come into Acadicus and check out what I just built. And ironically, it was actually a CVL exploring the contents of the CVL kit, I think was the very first recording he ever did. And we hadn't taught him anything. We didn't teach him. We didn't give him any training. We like nothing. He did it all on his own on a weekend. You know, he got the hardware and started creating 3D recordings, and he brought his residents in and had them go through the procedure. And then he created a post-intubation desaturation scenario for his residents as well to go through. And then they actually did a research study on how well the residents were prepared for the real world. And they did a comparison with the third-year fellows and seeing like how their experience compared with setting up for these different procedures. So they published that research in the Curious Journal of Medicine, which maybe I can share a link here, but if not, we'll be definitely talking about that on the 19th. And speaking of research, the UW team has published or will be publishing, they had a paper accepted this fall, and I think it's the Journal of Pediatric Medicine. I'm not sure if I got the title of that right, but a published study this fall. And then there's going to be a second study published next year that they're working on right now, which is what we captured the video for. And then by next fall, we're going to have a third paper published on their collaboration with physicians in Vietnam. So just amazing, amazing work they're doing there. So it'll be fun to hear more about what they're doing.
Yeah, that's amazing. That's really cool.
Well, let me share a few seconds of this video while I have it up here. And So what you're going to see here is, if I can figure out how to share my screen with video and sound.
While you're doing that, John, just wanted to welcome Kate and Sean and Stefan and Tanya to our session. And please, if you have any questions, don't hesitate to drop them in the chat. I'll keep an eye on that. And we can give you speaking permissions if at some point you want to have a discussion. Just let us know. We'll add you to the panelist list.
All right. Do you see my screen?
Yep.
So you see the video?
Yes, we have the video.
Okay, great. So what we're looking at here before we watch is, they're in a conference room. And one of the things I like to note about their implementation is that they, unlike Madison College has an amazing XR center, this is kind of a very different approach, what they have so far. Now they, I think, are envious and would love to have the same kind of XR center that Madison College has. But while they're working on building that, I think they do have...
Everyone.
I know, I think so. I think everybody has envy of the XR Center at Madison College. So they're working on building a VR lab. But in the meantime, they've got these laptops and they just bring them in whenever they want to run simulations. It takes them a few minutes to get them all set up and configured, and then they're ready to go. So we've got two physicians. On the left is Dr. Sarah Trin, and on the right is Dr. Ryan McAdams. They're going to be they're currently in the middle of a neonatal resuscitation. So they were paged, to attend to this patient, and they're going through the steps of this. So what we'll do is we'll watch a few videos from this perspective, and then I'll actually pull up Acadicus and we can watch a few seconds of the 3D recording that we captured within virtual reality.
It doesn't seem to be effective. So why don't we see if we can suction the airway? Or maybe something obstructing the airway. Okay. Suctioned. Still not seeing good chest rise. Our heart rate's still low. Our sats are still in the 50s. We're on 60% oxygen. They go up to 100% actually. Okay.
You might check over PBV so I can put the EKG leads on?
Sure.
Now, John, is this a scenario they created?
This is great point. So this is the Mr. Sopa scenario. So they're going through the steps for resuscitation.
Unfortunately, our heart rate is still low and our sats are still low.
I think we can go up on the PEEP a little bit.
Yeah, what would you like me to do?
Let's do 25.
Okay, there's 25. On the PIP, I went up on the PIP and the PEEP's still 5, okay?
Okay.
We're at 100% oxygen. Heart rate's still low, same with our sats, and I'm not seeing good chest rise yet. Let's continue that for a little bit longer. But we may need to consider an alternative airway at this point, since this baby's not responding to what we've done so far. I think we should go ahead and intubate.
Yeah, I agree. Let's prepare intubation equipment.
Okay, I'm gonna the laryngoscope for you, and as well as the endotracheal tube. What size endotracheal tube would you like?
Let's do a 2.25 ET2.
Okay. Here's your blade. When you're ready. Then I'll hand you the tube once you get visualization of the cords.
I see the cord too.
Okay, there's your endotracheal tube.
Tube in.
Okay.
See it pass through.
Yep.
3, 2.
Okay. We just got a color change. So I see yellow, which means we're exchanging carbon dioxide. And I'm actually seeing the chest rise now. And look, our heart rate's up to 120 and our sats are 90. I'm gonna lower the oxygen. And then looks like we're getting good chest rise. And I'm hearing good breath sounds on that side. Heart rate's good. Hearing good breath sounds on the left and right. They sound equal. And we're getting, so we've got good chest rise. There's mist in the tube. And I'm seeing the yellow color. So I think, and our vital signs are better. So, and the color's improved. What would you like to do next?
I think we should transfer the baby to the NICU.
That's a great idea. I'm going to go update the parents.
Pretty cool, huh? Isn't that amazing?
Very cool. Very cool.
I just love watching that. What there's, and Bill, you and I've talked about this in the past too, where there's a difference between when you bring a student into Acadicus and they go through a simulation and they don't have any professional experience yet, there's a very noticeable difference between how they approach a simulation and how people who are professionals who have been doing it for several years or many years, they just, you can see it immediately
Yeah.
when you're in VR,
Yeah.
like you said, the paramedics that you were training, they come in and they immediately are on their hands and knees and they're in and they're grabbing things and they're starting the leads and they're in there, and you can see Dr. McAdams and Dr. Trin, they're used to being in very urgent, very intense situations, but they're able to stay very calm as professionals. And it's really important. You hear the closed loop communication where they're saying something and they're saying it back, and they're very clear about their communications. They're staying calm. And I think that's the goal that they're after with the simulation, is to let people, intensivists, go through this experience enough time so they start to get somewhat desensitized to that sort of elevated heart rate and that nervousness, so that way when they're in the real situation, they'll hopefully be ready to stay as calm as you could see that they were staying in that video.
And that's a really important benefit of VR. I mean, I hear it a lot where I'll talk to people and they'll go, well, but I can't start an IV in virtual reality. I'm like, no, obviously you're not going to get that feeling, that feedback, that haptic yet. I mean, that might be coming, but but you're not going to get that. Where you're getting that haptic feedback, what it feels like to pierce the skin, those kind of things. Now, of course, I'd also argue that you don't even necessarily get that with your mannequin either, because the skin on the mannequin and the skin on the human are different things. But still, you're still getting that haptic feel. But that's not exactly the intention. The intention is not just, well, let's learn how to start an IV. Let's learn, let's learn what it feels like to feel the tube passing through the cords. No, that's not what we're looking for. What we're looking for is what we are really truly lacking in medicine, and that is that closed loop communication, and then just understanding how to work together as a team with a similar goal in mind, rather than I'm going to do this and I'll be over here, and I'm going to do this and I'll be over here, and we're not talking enough to each other. And even you could see American Heart Association went into it when they were talking about pit crew dynamics for CPR. It's the same general idea, is understanding closed loop communication, understanding what the other person's doing, making sure that we're rotating, compressors, those kind of things. And that's really where virtual reality stands out, because now you're getting put into that situation where you're completely immersed and you're looking at something that is extremely realistic in front of you. When you're playing with I shouldn't say playing, that's not right. When you're using the mannequin, you're still looking at a mannequin. You're still saying that is a mannequin, and you realize that's a mannequin. But so many of my students for VR, they've said, I didn't realize how realistic that patient was going to look, and stuff like that. So that's that real benefit.
Yeah, absolutely. So go ahead, Bill, go ahead.
Stephen said also expressed as learning process. Absolutely.
Absolutely.
Yep. And it can be used both in the lab environment and in the theory environment too. So if you're doing it as part of your class, you can do that as part of your class.
I always forget the shortcut for, I'm in the developer mode, so I got a little error there. Here, hang on one second. There's a shortcut, Control Alt Shift H. I got to remember that, Control Alt Shift H. There we go. All right, so this is what we're seeing here is the 3D recording. So Acadicus has a 3D recording feature where we can record actual procedures. We mentioned Dr. Sleeman is working on that CVL recording this morning. This is a recording of the exact same event that we just watched the video of, where we saw their physical bodies with the headsets on, but this is what they were actually seeing and doing in the virtual environment.
Yeah, this is great. And I just wanted to welcome Johnny to our attendees group. And again, reflect what you were seeing on the screen previously with them in the conference room working. This is what we recorded in Acadicus. So this is what they were actually seeing.
And John, I'm not hearing audio, so you might want to...
No, we actually muted our audio. Actually, wait, hang on a second. Maybe I can. No, we muted our audio in Acadicus so I could record video from WebEx. So we
Gotcha.
didn't actually capture. I think might actually, hang on one second. It'll be worth it if I can pull this off. This is live without a net, you know, this is what happens. Manage
That's the
my
way I
sound
like it.
settings.
I
Sound
like it on the fly
mixer.
like that.
If I turn that back, oh yeah, here we go. Can you
Hmm.
can you still hear it? Here we go. See if we hear them or not. We might not hear their audio.
Okay, I just set us at a pip of
Yep,
20 and a
I
pip
hear
of
it
5. And I'm just going to turn the oxygen up to 30% in the 30s to start with.
Yes, we've got their audio now, John.
Great.
I'm going to listen to just to see. Yeah, I'm not really seeing any chest rise. And I'm not hearing good air movement either. Okay. Clear the airway. Okay, it looks like you got a good seal. I'm not seeing good chest rise yet, and our sats are still really low, as well as our heart rate. I'm going to increase our oxygen a little bit. I'm going to go up to 60.
So we'll stop there. One second. Let me stop the audio on my end. There we go. So that was the virtual view. So, you know, the interesting thing about that is that, you know, really, you know, I'm not sure whether they're going to be sharing this or not, but hypothetically, you know, we could have that 3D recording that anybody could go in there and actually watch 2 expert neonatal intensivists resuscitating a patient. And being able to do that in the virtual world, you can look at it from any angle. You feel like you're really there. Anybody who's been in there and actually watched one of these 3D recordings, you feel like you're together with that person. And to watch them going through that resuscitation and be able to see it, you can actually get in there and see the vocal cords when they're intubating. And it's just a very immersive way. You could do it from anywhere, essentially. So.
Yeah, well, and you're getting to learn from people who you may not have met otherwise. I mean, you know, you're kind of shrinking the medical world there where, you know, you can start to learn from people that you wouldn't necessarily learn from otherwise. And I think that's another part of I think that's where I really love the 3D recordings. I'm trying to encourage my faculty to do more and more 3D recordings, because then I can take them and turn them into 2D, of course, and they can have them, you know, on their LMS. But at the same time, having their students then come in and watch your teacher go through one of these. Watch the teacher go through what you're about to go through. Watch the faculty do it. I think that's a really great way to demonstrate something. You know, and you can also do this sort of, you know, the Where's Waldo, right? Look for the mistakes. See if you can see what mistakes I made. See if you can see where I was going wrong, and how you would offer constructive criticism to it as well.
Hey, John, Tanya is asking if we can show how an avatar moves around the room.
How
Trying to
so
think-
in terms of teleportation, you mean?
Yeah,
Like
how
navigation?
yeah, I guess if there's more than one person in the room, how they move around.
That's a great question. So when you're in the VR headset, if you haven't tried it yet, you're basically holding controllers in your hands. And on the controller, within Acadicus, every platform's a little different, but when Acadicus, you basically point on the floor wherever you want your feet to be standing, and you press forward on that joystick and you move right to that location. So the advantage of that is that you can then move around a very large environment just by using that teleportation without actually physically moving your feet. So you'll see in some of our other customers, and I think Madison College might have this as well, there'll be kind of a physical sort of like mat that you're standing on, and you can feel when you get to the edge of that mat that that's kind of the edge, or there's like a boundary that pops up. Within your virtual field of view, there will be like a grid if you get too close to the edge. So you stay in one zone, but you can go from the delivery room, you can teleport out to the hallway, you can teleport over to the warmers, and you can teleport right up to the baby without physically moving your feet. So you could have, like when you saw Dr. McAdams and Dr. Trin in the physical environment with their video, they weren't really moving around physically. They were standing in the same place, but they were able to kind of move around the environment, you know, and get into position and rotate around. And So that's how we handle movement. So I don't know if that answers your question, but that's kind of how we handle teleportation.
I even did it with a broken foot back in the beginning of 21. I had a broken foot and I was sitting in a chair a lot like this one, and I had my foot up and I was doing virtual clinicals with my students where they were joining me, via viewer mode, and then they were essentially telling me all the things that I needed to do, and I was picking things up, and I was just teleport, 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 grab, teleport, teleport, put this on, and once they get used to that teleporting, it's really easy. Once they get used to teleporting, they pretty much stand still. I've noticed a lot of our students will more or less just stand in one place and move around, and they don't even do as much moving of their head because you can bump on the joysticks on that to get it to move your head position. And so they actually more or less stand in one area. Now we have our play areas here are about 6.5 foot by 6.5 foot. So that's what we have inside of those barriers. And the physical barriers, they're more or less just to give the student an idea that they've gone too far. There's already a kind of a barrier in there that tells you about setup, but when they come up to it, it just kind of lets them know they've gone a little too far, and that's what we've used. So
Yeah, and I think it's like that. That's like the Xbox controllers when before we had the motion controllers, the early VR headsets came with a controller where you could you move using your joystick. So basically, like in a video game, you press forward on the joystick and your view just kind of moves slowly. And what we learned early on, I'm extremely sensitive to motion sick, like one of the worst. Like I get motion sick sitting in a rocking chair. So I told the development team early on, if we're going to build VR, it's got to be something that doesn't cause motion sickness because I can't tolerate it. So we learned early on that it's called a vestibular mismatch when you've got the Xbox controller that you're using the controller to move forward, and your visual field is perceiving movement, but your inner ear isn't having a corresponding physical movement. Then that causes that mismatch that causes you to feel motion sick. So by teleporting, all you're doing is pointing where I want to go. You press there and you're instantly there. So there isn't that like slow motion movement that causes that motion sickness. So teleportation, for the most part, I don't think I've ever heard anybody say they're getting motion sick from teleporting. Like that's a pretty, safe and comfortable way to do it. The other alternative is to not have any kind of assistance. So you just walk around freeform. And, that's something that some of the newer, just being able to have a very, very large area to walk around in and not teleport and not use any kind of joystick. The challenge there then is you need a massive amount of space to be able to run a simulation because you got to move around. In a lot of our simulations, like especially like the mass casualty one, you're in a whole downtown space. You can't just walk around. Most people don't have a sim lab the size of downtown Madison, right? So you gotta teleport. You got to be able to teleport. So that's how we handle that.
yeah, absolutely. Yeah, I found when I've done some of the meta stuff where, like in Meta Horizons, when you go into Horizons and you're moving around in those, what it does is it closes off the areas around you. It sort of creates almost a tunnel vision effect. And that's supposed to make it easier because you're not seeing the immediate movement right here by your eyes. And honestly, that didn't necessarily work for me. And teleporting has been the best way for me. I have no problem with I'm here and then I'm there. That doesn't bother me at all. And I'll teleport two-handed and be holding on to things and teleporting, and that doesn't bother me at all. But when I go into something like Meta Horizons or something like that, and I'm moving around through an area, and it's got like that slow movement, I can't. I can do it for a little bit, but I can't do it for very long. So
Same.
yeah.
Yeah, any of the attendees that are with us today, if there's anything you'd like us to show you in Acadicus, how we do things, how we perform or move around or build or manipulate things, let us know in the chat. We'd be glad to pull the application up and jump in and we'll go through a little demonstration. In the meantime, otherwise, Jon will just pull some content up and maybe look at our pediatric pain scenario, since it's pediatric simulation. I
That's a great idea, Rick. Let me pull that up. Hang on a second.
think
I
that's
know
in
the
our.
voice for that one. The voice for that one trips me out really bad.
That's
My-
right. That's
it's,
right. That's your daughter.
it's my daughter, and she she said I think it's supposed to be a 7-year-old, and she was 8 at the time, and she's like, I'm like, you think you can be a 7-year-old? And she's like, I don't know. That's and then she kind of critiqued it too. She's like, I don't really think a 7-year-old would say that. Maybe you need to tell John that I don't think a 7-year-old would say that. And so we did. John, Anne-Marie does not think a 7-year-old would say that. So
And John and Bill, Stefan is saying one of the things he has a question about, and Stefan, I'll ask you to expand on this a little bit, is rectifying a participant error. Rectifying a participant error. If you could elaborate on that, it would help guide us to make sure we're answering your question.
yeah, and I guess, are you talking about medical? Like, am I giving, is it like formative assessment where I'm rectifying a medical error that they made, or maybe that's the benefit of it, correcting a medical error? Yeah. So
You have a great story about this, Bill, with the
What's that?
atropine adenosine.
Yeah, and for those that watch SimPulse, here it is again. So I had a student that was in VR, was working at cardiac arrest, and I had put the patient into SVT. So patient's in SVT, heart rate's right around 170. He's in unstable or stable SVT. Okay, so blood pressure's fine. He's not having chest pain, no shortness of breath, nothing like that. Feeling a fluttering in his chest. I was acting as the patient, so I was just saying I was feeling a fluttering in my chest, right? And so the student said, "Okay, I want to give 6 milligrams of atropine." And I sat there for a second, because again, I'm the patient, but I was also his assistant. And I said, "Okay, copy 6 milligrams of atropine." And he said, "Yes, let's do 6 milligrams of atropine." And I went, "Understood, giving 6 milligrams of atropine." So I closed the loop and I gave the 6 milligrams of atropine. I said, 6 milligrams of atropine on board. And he said, "Copy 6 milligrams of atropine on board." And if you know atropine and adenosine, right? So adenosine is meant to slow your heart rate down, and atropine is essentially meant to speed your heart rate up. And so I went, okay, this is outside of what I had originally written for the scenario, but because I can change all of the vital signs in Acadicus on the fly, I just went, okay, fine. And I just dragged that heart rate all the way up to about 200. And he was like, whoa, 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 what happened? What's going on? Now, the truth is 6 milligrams of atropine, that's an overdose of atropine. But I wanted to give him this example. And I ramped it up to like 200, 220, and he goes, whoa, what's going on? What's going on? And I said, well, you gave him 6 milligrams of atropine. And he goes, no. I wanted 6 milligrams of adenosine. And I said, well, you said 6 milligrams of atropine, and I closed the loop and said it back to you. And you said, yes, 6 milligrams of atropine. And he goes, well, I meant adenosine. And I was like, well, it doesn't matter what you meant. It's what you said. And so if you've got a newer partner, you're a paramedic and you're working with a new EMT partner, and he doesn't know the difference between atropine and adenosine and what they do, you're kind of in trouble. And so that was a great teaching moment to say, okay, you got to make sure you're 100% sure what you're going to say. He's like, we don't even carry 6 milligrams of atropine. Like, I agree, we don't. But in this scenario, I wanted to see, could we go in this direction? And that was the other thing is, because I could manipulate the scenario in real time. So I just went and, moved the heart rate up. So yeah, that was one of the things. And it was formative. It wasn't summative. With summative, I would not correct. With summative assessments, I'm going to let the student go down rabbit holes that they're going to go down. But when it comes to formative assessment, that's where we should be saying, okay, stop, hold, let's talk about what went wrong here, right? And because I can change all of those things on the fly in Acadicus, it was easy to just go, okay, well, I know what he meant, but I'm going to change this. If I had it where it was set to only that scenario and I couldn't change it, then what am I going to do? I can't change the vitals. I have to act like he gave adenosine and then later on go, hey, you said atropine instead of adenosine. But I wanted him to see the actual, what would happen if he actually gave that medication, or what theoretically would happen if he gave that medication. So, yeah.
Even
that's
Stefan,
awesome.
I hope that answered your question. We've got a couple of more here. I just want to take them in order. Tanya is asking, does this program have pre-built scenarios, or is it designed for us to create our own? And I've mentioned in a quick message back to her that we have both, but that we can elaborate. And John, I don't know if you want to share your screen. I mean, Tanya, we shine in the ability and we focus on the ability for our community to be able to create their own scenarios, right? Your own scenes from scratch, determining the environment, the characters, the assets, what your learning objectives are, and you can put all that together. But yes, we do have a library of pre-built content that's in there that you can use out of the box, so to speak, ready to go, documentation supporting behind it, and you can run with it. But I will say, because I do a lot of the training with our new customers, that without a doubt, even with our pre-built scenarios, the minute I get a subject matter expert in there, whether it's our hazard room or pediatric pain scenario or OB suite, these folks get in there and they immediately have things that they want to change, right? No matter how much practice we put behind building these things, you take an OB nurse into our OB suite and right away they're like, oh, well, can you put this over here, and can we have that? And I don't see that in the room. And so we are designed for you to use all of the assets and content that we provide you, and even bring some of your own content in to build out these experiences to meet what your needs and objectives are. And I think John's bringing up now to kind of show you some of that content.
Yeah, like right on our website, I just want to mention, there's content and there's tools. The content is where on this page, it'll show you all the different content, patients, environments, scenarios, and these are all the different scenarios that are in there. Some of these, like the Foley catheter, lumbar puncture, NG tube, these are going to be self-guided scenarios. Some of them are going to be more requiring a facilitator. So you'll have some scenarios, like a lot of the OpenRN scenarios are like that, where they'll be basically you're using a simulation manager to choreograph a live simulation where the student is interacting and making decisions in real time. And then you're doing live facilitation and debriefing rather than just having the student go off by themselves and do the scenario that are pre-programmed with these 3D recordings. I also wanted to share that I'm going to open up Acadicus, but if you want to get in here and try this yourself, if you go to support at acadicus.com and go to download, and also hardware requirements are here as well. If you're curious about the hardware requirements, those are outdated. We're about to be updating our hardware requirements page. So just a note on that, it hasn't been updated, but our website is undergoing a slow update. Each of the pages is getting updated, and we're going to be updating the hardware requirements page soon. But if you go to this download page and enter your email address here, you download the client. And if you have compatible hardware, you'll be able to install that and get in here and see everything that I'm about to show you on your end for free without any charge. So
and John's going in viewer mode here, so you can go in viewer mode on most computers. I mean, my HP work computer has no problem with this. I've downloaded it on and I've gone into viewer mode, and then to go into like virtual reality, put the headset on, you need that equipment to do that. And one of the questions you asked was like the preset stuff, can it be like sort of changed? Yes, some of it can. And like I'll give you an example. So my nursing faculty came to me and they said, here's a scenario that we use in our sim lab, okay, and we want to use this same scenario in our sim lab and in VR because we want to kind of make a comparison between the two, right? And so I said, sure, no problem. Let me see the simulation. So they gave me the simulation. They told me this is what we wanted. And I looked at it and I went, okay, yeah, no problem. And so then I went in and in there I said, okay, I'm going to need a Gen 2 mannequin. So I put a Gen 2 mannequin in there. All right, I need a life pack monitor. Boom. So I put the life pack monitor in there. I'm going to need that. And I put these things in there. And then I had the faculty come back, take a look at it, and they went, oh yeah, that's great. Okay. But hey, do you have this and this and this and this, right? Do you have a clock? We can put a clock on the wall. Yeah, here, let me grab a clock. Put the clock on the wall, right? Because they wanted the students to be able to have some idea of the amount of timing between their medications, their assessments, those kind of things. So I've done both, where I've used like Bjorn McClellan, who is a great asset. And I've used Bjorn as sort of he's more of a preset, and it's a scenario based on, it's based on a specific scenario. And I use Bjorn. But the nice thing about that is, like, if the student, like we had the student, they put the nitro patch on, and they gave him the sublingual nitro, like at the same time. And the nursing faculty sitting next to me going, you know what, why don't we lower his blood pressure? Because I think that would lower his blood pressure. So let's do that. Make him a little dizzy. I was like, okay. So I lowered his blood pressure and said, boy, I feel a little dizzy. And they were like, oh, okay. Oh, uh-oh, what's going on, right? So we were able to sort of still on the fly make those changes.
Yeah, absolutely. And here's the patient. And I also wanted to share, if you just Google OpenRN or go to our website and go to the OpenRN scenarios, you'll see that there's, on this particular page, if we look at cvtc.edu, this link I'll share in a bit, but we can see right here is view all the OpenRN virtual reality scenarios. You'll see this whole list of the scenarios that are in. Each of these will be available, or already is available, in Acadicus. And we're going to be going into the pediatric pain scenario, and there's a scenario plan for that. So before you go in, a facilitator or your sim ghosts or your technicians or whoever's going to be helping run this can review the scenario plan and see even how the scenario is laid out, what the curriculum alignment is, learning objectives, the setup. We've got different states of the scenario, what the expected student behaviors are, prompts, questions, teaching points, suggested debriefing, and of course a whole rubric and feedback with references as well. So you can go through that before you actually come in here. And as a facilitator, I'm logged in as an administrator, and I happen to be in the commons at this point. This is a demonstration lab that we have available. But as an instructor, I would open up my simulation manager. I can select the patient, and here's where I can control all the different variables for her. So the student they wouldn't see that I'm in the scene, because I would go into ghost mode, which I do right here as a sim ghost. So I'm the technician now. The student can't see me anymore. The learner cannot see my avatar, but I have the ability to puppeteer and choreograph, just like in a sim lab behind the mirrored glass. I'm helping facilitate. We could have somebody playing the role of the patients, or we could have this pre-programmed voice panel. So I'll play a few of these.
Where's my mommy? It hurts. My throat hurts.
Eventually your daughter's going to
My
get
throat
older,
feels
and
better
this
now.
is going to be fun to come back and say,
Right,
listen what
right.
she used to
I
sound
want
like.
to.
Yeah.
So
Yeah, and so too, yeah, sorry, that train ran off the track because I was hearing my daughter say, my throat hurts,
shaking her head. You can
Yeah.
have her lie down, arms crossed, arms resting. So I think the scenario is she wakes up in a lot of pain, and we already kind of stopped on the learning objectives there, but I think you're looking, I'm going to try to move my camera as slow as I can here, but we're looking at the Wong-Baker pain rating scale essentially as part of the learning objectives here, to get a sense of just how much pain she's in, and then we can make an appropriate intervention from there.
And because I operate from viewer mode, when I'm acting as the operator, I'm sitting right here, and the students are over there in their respective, we don't do any more than like 4 in a scene at once, because if you have 4 students in the scene, anything more than 4 seems to be kind of chaotic. So we don't really have any more than 4. Usually we're keeping it to 3. So it's the 3 students, I'm in as the operator, and then the faculty members usually around here. I'll put it up on the big screens up here, too, so that the faculty member can sit and watch. But then because I'm in viewer mode, I actually take the scenario, I print it out, and I sit it right next to me. And that way I can always reference back to that scenario to make sure that that's exactly what that faculty member wants. Or they can come over to me and they can kind of whisper in my ear like, hey, lower the blood pressure, or hey, the heart rate would change here, or something like that. So that's usually the way that we handle that. So
I have a couple of
No.
questions I want to make sure we addressed. And Stefan, I dropped a bunch of text into the chat that I hope is helpful to you in regards to hardware, but basically any headset that will operate in Windows virtual reality PCVR, we can work with. And so you can see there's a long list: Meta, HTC, Reverb, Valve, so on. So, and I'm glad to get with you and go into detail on that more if you'd like. Stefan also asked about, do you plan a scenario involving a gunshot wound in combat or domestic location? And I can tell you that we're getting ready to come out with our trauma patient. Jon, is that this month?
That is a question for Stefan, would know more about content than I do, as far as timelines goes, but coming up soon.
Yeah, it's definitely coming out in the next, I better be careful with, promising dates, but it's in the last stages of being worked on and I think validated. So yes, and that's going to be a combination of gunshot and/or knife wounds, trauma patient, and because of the way our platform works, that trauma patient's going to come out in a trauma room with the intent for, assessment and activity by trauma physicians. But then, just like with all our other scenarios, we'll be able to take that trauma patient, and if you want them laying on a, street curb in the city, we can do that. You can do that, right? With Acadicus, you can put that patient anywhere. It doesn't have to be in the trauma room. It's a asset that you move around and use based on what your objectives are.
I want to put it in the dental clinic. That's not a joke. I actually want to do that and see, like, how are my students going to deal with it, right? I once got a call for abdominal pain. This was years ago. I got a call for abdominal pain, and I get on scene, and there's a guy, he's kind of huddled over like this, and he's like, oh, and I'm like, hey, sir, how you doing? You having some abdominal pain today? And he's like, oh, man, it's awful. And I'm just going, okay, well, let's take a look. And he takes his hands away, and he's got a knife sticking out of his belly. And I went, okay, yeah, that's going to cause abdominal pain. What? And then immediately I started looking around like, what's going on, right? I want my students to have that same level of confusion. They go to a dental clinic and they're getting called for an incident or someone who came into the dental clinic and has a medical problem. And, maybe this person ran into the dental clinic and sought refuge in the dental clinic and he's stabbed in the belly, right? So, like, that's the key, is that my sort of strange mind can come up with those things and go, I want a stabbing wound victim or a gunshot wound victim laying next to a dental chair.
Mm-hmm.
Like,
we can do that.
What happened, right? He ran in. They'll say, hey, he just ran in and he pushed us all out of the way, and then he collapsed right here and he was screaming, help me. We don't know what's going on, right? So you get called for a man down. They don't know the guy's shot or whatever. You get a call for a man down at the dental clinic. It happens a lot. Happens a lot. My paramedic friends will say, yep, that would work. Yep, that would work.
Didn't Mitch Luker from NWTC just create a scenario with a birthing patient that's going into labor in the dentist office in the dental chair?
Perfect.
Oh my goodness, that's great.
Isn't that one of the scenarios? I think.
Why not? I know
well,
it
was a trauma scenario where it was a resuscitation of somebody that had a cardiac incident, I believe, in the dental office, sitting in the dental chair. And then while they were in there, they also added the OB patient to the childbirth patient to one of the patients. But you never know. You never know.
Well, I know one of the most fun experiences I had was working with the Department of Army Research, where we were creating the burn victim patient for them. And it wasn't ready yet. So what I did is we took some of our regular models, and we have those inking utility pens in there. And so I was able to, take the posterior upper chest area, back area, take that red pen and represent, an area of burn, right? And we were able to kind of use that to represent, in the VR scenario that, hey, we have this burn area here. Now let's apply rule of nines. Let's talk about depth of burn, right? They wanted to cover these 3 areas. And then we took that same model and they said, just what Stephen's asking here, hey, what if you're not in the hospital? And so we took them to our wooded area, and I put some of our tent assets out, right? And we have this gunshot sounding loop that we were able to play. So it sounded like we were off in the midst of a battlefield. And we put the model there with the burn, and they were in the field, and they didn't have all their equipment. And it was like, now let's talk about how you stabilize this individual in the field. What do you have to think about? Again, applying rule of nines, figuring out your fluid resuscitation, figuring out depth, stabilization, and then getting them to a facility. So it was great. It was a lot of fun putting that together.
Stefan said, suggest when you do create the scenarios, include the situation where the victim only has minutes to live, creating huge pressure on the providers. Yeah, the great thing about it is you can create that scenario. It's your scenario. It's a sim lab. It's your sim lab. You then create that scenario. So you go, I might say, this is for my EMT providers. I want, especially brand new ones, I want them to kind of, get into it a little bit and still feel like they're not being thrown in the deep end. But then I have my final year paramedics who have already done their field internship. And yeah, now I want that. Now that patient is crashing on them and the vitals are, going down and all of that. You can do that. You can just go, you know what? I'm lowering the blood pressure. And in real time, you just go, lower the blood pressure. So it's not bound by a specific scenario. It's your scenario. Take it and put it in there, what you think is going to work best for your patients versus like what we think would work best for your patients,
Yeah, and I know when I work with organizations, one of the things is oftentimes instructors are learning how to teach in these environments. And it always starts with the planning aspect. And I always ask them, okay, are you dealing with first semester students, second semester students, third semester students? Because you're going to introduce it differently based on where they are in their experience and their study, right? You're not going to, Bill, like you said, throw them in the deep end if they're, their first semester students still trying to figure anatomy out versus your fourth semester students who are getting ready to go into the workforce, and they have to deal with, the 4-bay unit and between shift handoff and juggling multiple priorities and figuring out how to best take care of a group of patients.
Right.
And so, you see the 4-bay unit used a lot in our first semester students, right? They're in the single room with Millie kind of doing assessments. But in the fourth semester, they're in the 4-bay unit and they've got 4 Millies, and, they all have competing priorities and they're trying to figure out how to balance all that.
Yeah, absolutely. And this is the 4-bay that we have up here. And I was just sharing, this is one of the scenes that was created by the team at Nemours DuPont when they were running mock codes. They ran a bunch of mock codes, especially during the pandemic. They were running simulations here. They were sharing over Zoom, and a code leader could join in and go through the steps of a mock code. So I'll share just a few seconds of a video here that shows what that looks like in practice. So we've got the Zoom window on the right. We've got participants joining from all over the world on the right on Zoom. And then we've got several participants. You can see Mitch Luker was in Green Bay, Wisconsin. Dr. Slayman's going to be in Wilmington, Delaware. Jeff is up, I forget where Jeff was, somewhere in Indiana. And you'll see them running a scenario here.
And isoflurane is actually a very potent bronchodilator and vasodilator. But you can bronchodilate people and keep them from the end pathway. So Emily, you said you're going to match in pediatrics. Every mock code for the rest of your life, the final step is always ECMO. We're definitely not going to go ECMO in this circumstance. But if Jeff and Mitch think he's not awake enough, maybe we should walk through the steps of intubation as the next step. So what do you guys think? Per kilogram IV Q6, but Mitch is putting in an IV for you and we can get some Solumedrol over.
That's perfect. And then I'm assuming we've kind of checked out his airway, just given him like a little suction, maybe consulted RT.
So yeah, Jeff has a Yankauer suction up there. He can definitely make sure there's no secretions and suction him out for you real.
So you can see the simulation there, and this is the scenario. And then afterwards, they'll have the debriefing, and we've got a little, you know, they created this as well. They've got a debriefing where they've got all the different ACLS and PALS algorithms. They've got the H's and T's. They've got a diagram of the heart, so they can go through some of that. And a lot of times they'll have imaging and lab results as well that they can bring up. They've got some of the imaging in some of these environments right now. We can see this patient has one. I think there's another one down here where if we go in here, we see this patient also has a imaging, and we can see Millie's in the corner. Millie's a family member this time. So Millie isn't always a patient. Millie can also be a family member. And we can see lab results on the wall here. So, or on the other side there. So,
And those are the lab results that are chosen by the instructors, not by us. We're not putting the lab results in there and saying these are the lab results you should use. They're chosen by the instructors. My instructors come to me and say, these are the lab results I want, and this is the format I want it to look in. And they hand that to me. I make an image out of it and I put it into Acadicus for them. And then their information is on the wall, not, all we've got in here is this one and this is the way it looks and that's it. No, they tell me, especially respiratory therapy, because they have, what ABG levels they want and all of that. And so I said, whatever you want those ABGs to be, just send it to me. You can send it to me in a Word format, or if you already have a format that you like it to be in, or you want it to look exactly like the labs do, where you would get, give me that, and I'll create that, and then put that image in Acadicus. And then that way they're using their ABGs, their labs, their chest X-rays, right? Our respiratory therapy instructor, she has specific chest X-rays that she wanted to use. So I said, just send me the chest X-ray, send it to me, as a picture or whatever, and I'll cut it and then I'll stick it in Acadicus. So it's their chest X-rays. It's their information, not stuff that's pre-built. Now, of course, there's pre-built and you can use that, but it's not always, it doesn't have to be that way. You can put in what you like.
yeah, and where that really becomes powerful is if you've got, in the case of a children's hospital like this, they can model specific patient characteristics before the patient arrives on the floor. So they can actually say, especially if there's a patient that's going to be coming in that has a rare or unusual condition, and they want to make sure that they're ready for, any possibility. Once they know how to use the software, they could jump in and in, a few minutes, I think any of us know how to use it well enough that, if they're trained up on how to use the editing tools, they can very quickly change the values and say, okay, here's a mock-up of what this patient is going to be presenting with, and they can go through and make sure they're ready before the patient even shows up. And they've actually, I think there's been several incidences where they've actually done that, and it's been very beneficial in their ability to care for those patitions. So I'm hoping we have more of that happen. Yeah, I imagine
usage.
Yeah, I imagine a day when there's a simulation bay, on the floor of every hospital, right? And you never interact with a patient unless you've practiced virtually first, because there's really no reason why we can't at this point. It's pretty easy to be able to create these mock-ups and go through and make sure your whole team is up to speed and ready to go. And I think we could reduce errors and save lives if we get that going.
And you could even speak to other experts within the field. You could say, Dr. Smith is an expert in this. Dr. Smith's over in China or something like that. And I'd really love to be able to talk about this. Could we do it? And that's a very good possibility.
Absolutely. I think this is the scenario you created at one point we were just talking, I think we were working on like multiple casualty downtown. Oh no, this isn't the one. Actually, this is airway ready. This is the one that Dr. Sleeman did for the post-intubation desaturation. So they go through those steps, but the names are very similar. It was,
We've done that multiple times. Yeah, it's pediatric respiratory distress.
that's the one, yeah.
Yeah, because we were talking about so this is 2020. This is mid-pandemic. Our students are not getting respiratory patients, and our students are not getting pediatrics especially. And so we needed pediatric patients and we needed respiratory patients. And so one of the ways that we did that was we created this scenario. Now this is before this became the pediatric pain scenario with my daughter's voice, that literally just ran me off the rails, y'all. Like, I mean, I knew that was in there, but it ran me off the rails because she said my throat hurts. But so yeah, this is John and I were in and going, I said, I'd really like a pediatric respiratory distress, maybe an asthma patient. And John is sitting there grabbing stuff and putting it in and going, oh, no, no, no. And he's just listening to me talk and he's going, yep, and I'll put that in and I'll put this in and I'll put that in and I'll put that. And I'm like, okay, do we have a nebulizer? Can we get a nebulizer? And he's like, yeah, hold on, and a nebulizer appears magically and then it's in the bags and obviously the blue bag is their respiratory bag and the red bag is our medication bag. But what's going on with this patient actually is she's downtown with her aunt, who is not her guardian, so to speak. So there's another level of like, what do I do there? But they were downtown, and she left her sitting out here by these flowers. And as it turns out, she's having a bit of an extrinsic asthma attack because of flowers, right? So that would happen to me. And John and I I'm just throwing this out there. I'm like, well, what if she started having an asthma attack because, I don't know, some flowers? And John's like, oh, flowers. And he grabs some flowers and sticks some flowers in there. And he's like, yeah, she's having an asthma attack because of flowers. And that was it. And then it was that quick that the scenario was created. And then I went, well, okay, I'm going to start using this with my students. And there it was.
And I think this also, Stefan, addresses a question you had earlier about, do we have scenes or settings outside the four walls of the hospital? So you're getting a really good view here of our cityscape environment that you're able to use. We use this for mass casualty incident as well as safety and falls from the building. Lots of different things that you can do with this.
I did a fall safety pretty much where John is standing. We have a mass casualty that goes throughout this area. And then further down the street, I had created a patient that was having chest pain. And so I just chose different areas. And obviously I created a new scene. So I can have it all be the same scene, or I can have it be new scene or whatever. And so that's kind of what I did there was I just, just bring patients in and put them in that environment. There's benches around, sit them on a bench. I think John, when we were doing the mass casualty, John's just grabbing patients and going, one there and one there and one here. And then I'm going around and checking the board. Okay, what would this patient be? That'd be, this is a category green, or this is a category yellow, or here's a red, right? And that was it. And I think altogether we took about 2 hours and we made it from, pretty much from scratch.
And that is the scenario that's in the commons now. So if you follow the steps earlier and go into the commons, you go to the multiple casualty scene that's up against the wall. When you go in, it's on the right side on the back wall. And check that out. That is the scene that we configured a few weeks ago.
Yep.
Well, we're at the top of the hour. Another Simulation Pulse Live.
Yeah.
So we don't have any specific plans for next Friday, but the Friday after that, April 19th, 12 o'clock Central, we're going to have a great panel pediatric discussion, and we hope to see you there. Thanks everyone for joining. Have a great weekend.
Thanks for joining all.
Take care, everyone.